When patients develop severe gram-negative infections, like sepsis, clinicians deploy aminoglycosides. Drugs like gentamicin and amikacin are heavy-hitting antibiotics required to clear out aggressive pathogens. But these drugs carry severe biological constraints. If managed incorrectly, they cause nephrotoxicity, shutting down the kidneys, and ototoxicity, destroying the hair cells in the inner ear to cause permanent hearing loss. Medical intuition suggests a clear response to a highly toxic drug. You lower the total dose, or split it into smaller, frequent increments to avoid shocking the patient's system. The modern standard of care for aminoglycosides dictates the exact opposite. Clinicians administer a massive, highly concentrated single bolus, and then intentionally leave the patient without any medication for a prolonged interval. Maximizing the instantaneous concentration of a toxic drug appears reckless, yet this specific dosing protocol minimizes permanent tissue damage. The answer to why this works lies in the competing kinetics of the bacteria and the human host. To understand the kinetics, we have to look at what the drug does once it penetrates the bacterial cell wall. The aminoglycoside molecule targets and locks directly onto the pathogen's protein manufacturing center. Specifically, it binds to the 16S ribosomal RNA within the 30S subunit. This binding is irreversible. The drug forces the ribosome to misread genetic code. Protein elongation halts, mutant proteins are synthesized, and the bacterial cell wall undergoes a cascading structural failure. This irreversible ribosomal binding guarantees bacterial death. It is the root of the drug's potent bactericidal power, and it dictates the first absolute requirement for how the drug must be dosed. Standard antibiotics, like beta-lactams, operate on time. Their success depends on how long the drug concentration remains above a specific threshold, known as the minimum inhibitory concentration, or MIC. Aminoglycosides operate on a different principle entirely. This chart models concentration-dependent killing, plasma concentration versus time, with the MIC baseline. The relationship is brutal. The higher the peak climbs above the MIC, the more complete the eradication. This is the Cmax. Clinicians also track area under the curve to clear high-burden infections. Hitting an optimal Cmax of 8 to 10 times the MIC, while simultaneously fulfilling the AUC volume, physically requires an exceptionally large initial bolus of the drug. Efficacy demands this initial massive spike in concentration. To guarantee the pathogen dies, the patient must be exposed to an extreme amount of the drug up front. But an extreme dose cannot be maintained. As the kidneys clear the drug, plasma concentration plunges below the MIC line. Normally, bacteria would resume multiplying here. Instead, we observe the post-antibiotic effect. Bacterial growth remains completely suppressed even when plasma levels approach zero. This traces directly back to the drug's mechanism of action. Because the aminoglycoside molecules bound irreversibly to the 30S ribosomes, the surviving bacteria remain functionally paralyzed. They cannot immediately recover or replicate. The post-antibiotic effect solves a major clinical problem. It allows clinicians to leave the patient safely in a drug-free state for hours. Antimicrobial pressure is maintained without adding a single drop of new medication to the bloodstream. While the bacteria are paralyzed, the human body is actively processing the drug. We must examine the specific human organs tasked with clearing the medication to understand the side effects. Aminoglycosides are positively charged. Filtering through the kidneys, they bind to the proximal tubule cells, which swallow the drug inward through endocytosis. Once inside, the drug accumulates in the lysosomes. It disrupts phospholipid metabolism, shutting down cellular function and triggering a drop in the kidney's glomerular filtration rate. A similar pathway dictates ototoxicity. The drug passes freely from the bloodstream into the delicate hair cells of the inner ear. Inside the ear, the drug attacks vestibular and cochlear mitochondria. It generates reactive oxygen species that rapidly cause irreversible cell death, permanently destroying the patient's hearing and balance. The mechanism of toxicity is clear. Prolonged, continuous exposure of these specific renal and auditory tissues to the drug guarantees their cellular destruction. Biology provides a loophole. The uptake mechanisms in both the kidney tubules and the inner ear are strictly governed by saturable kinetics. Consider the traditional dosing model. In this approach, the patient receives multiple small doses of the drug, administered evenly throughout the day. Because the concentration in the blood is maintained continuously, the receptor gates in the kidneys are constantly active. They pull in a steady trickle of molecules, leading to severe toxic accumulation inside the lysosomes over time. Contrast this with the high-dose extended interval model. The system is hit with one massive bolus. This instantly overwhelms and jams all tissue receptors simultaneously, physically saturating them. The locked cells cannot absorb more. The vast majority of the toxic dose simply washes past, safely excreted. This is where the long drug-free trough becomes vital. The extended interval provides the saturated cells the necessary time to process the small amount of drug they did ingest, allowing the tissue to fully recover before the next dose. The paradox is resolved. A massive single dose causes significantly less intracellular accumulation than smaller, frequent doses, because it weaponizes the body's own saturation limits. Look at this complete dosing curve. We can now map all three biological phenomena onto a single, unified clinical model. The extreme peak achieves the concentration-dependent killing required to rapidly clear the bacteria. The deep trough creates the physical safety window, allowing saturated tissues to clear the drug and recover. And the prolonged timeline operating below the MIC utilizes the post-antibiotic effect to maintain continuous antimicrobial pressure. Every extreme phase of this curve is a deliberate calculation. It exploits the different kinetic limits of the bacteria and the human host to achieve maximum efficacy with minimal damage. This kinetic manipulation is the exact reason hospital frameworks like the Hartford or Stanford nomograms dictate highly specific, extended interval orders for severe infections. Mastering the mechanics of saturable kinetics and concentration-dependent killing empowers clinicians to do their jobs. They can confidently administer lethal doses to resistant pathogens, knowing they are definitively protecting their patients' vital organs in the process.